everyone, welcome to TryRide. This is Pack 365, myself Srija. So today in this video, you're going to learn about the chapter 2 ICD CM guidelines about neoplasms. So chapter 2 neoplasms. So the code series is C00 to D49. So what is chapter 2 in ICD CM? So chapter 2 of ICD CM contains codes for neoplasms, that is tumors. So these include all malignant neoplasms, that is cancers, most of the benign neoplasms, in situ neoplasms, and neoplasms of uncertain or unknown behavior. Some benign tumors are not in chapter 2 and they are found in body system chapters. For example, benign prostatic hyperplasia in the code N40. So what are the general guidelines for neoplasm coding? So first, determine the behavior of the neoplasm, whether it is a benign behavior or in situ behavior or primary malignant, secondary malignant, uncertain behavior or unspecified behavior. So benign behavior, it is nothing but it's a non-cancerous neoplasm. In situ behavior is a cancer present but not spread. Malignant or primary neoplasm is it's an original cancer site, whereas secondary malignant neoplasm or secondary malignant behavior is a metastatic site from where original cancer site is spread to a different site is called as a metastatic site. So uncertain behavior is a pathology unclear, whereas unspecified behavior, it denotes that there is no behavior documented. So if the provider does not clearly document behavior, you have to code D49, which is for unspecified neoplasm. And second, identify the primary versus secondary metastatic cancer. So primary malignant neoplasm is nothing but it's where a cancer started, whereas secondary malignant neoplasm, it is a site to which the cancer is spread. For example, breast cancer with bone metastasis. So C50 code for primary breast cancer, C79.51 for secondary malignant neoplasm of the bone. So you have to code both primary and secondary sites when documented. So next, what are the overlapping site neoplasms? So what does this overlapping site mean? So an overlapping lesion, it occurs when a single primary malignant tumor crosses two or more adjacent anatomical sites and the exact origin cannot be determined. So what is the coding rule? You have to use subcategory 8 for overlapping lesion. For example, cancer involving upper and lower esophagus. You have to code C15.8 for overlapping lesion of esophagus. So overlapping codes, they apply only to the primary malignant neoplasms. So next guideline is about multiple neoplasms in the same organ, that is non-contiguous. So if separate tumors exist in different parts of the same organ and they are not touching, so you have to code each site separately. For example, tumors in upper outer quadrant and lower inner quadrant of the same breast. So you have to assign two separate codes, not an overlapping code. So touching is nothing but overlapping and separate is a multiple codes. So fourth guideline, malignant neoplasm of ectopic tissue. So what is ectopic tissue? Ectopic tissue, it's a normal tissue located in an abnormal place. For example, ectopic pancreatic tissue in the stomach, ectopic thyroid tissue in the neck. So what is the coding rule over here? Malignant neoplasms of ectopic tissue, these are coded to the site of origin, but not where they are found. So example like ectopic pancreatic cancer involving stomach. So you have to code to pancreas, not stomach. So C25.9 code is assigned for malignant neoplasm of pancreas unspecified. So you have to always code where the tissue belongs, but not where it is located. So the fifth guideline is you have to use the neoplasm table first. So always start with the neoplasm table in the alphabetic index. So then verify in the tabular list. So never code neoplasms directly from the tabular list. Next is history of malignancy. So if the cancer is no longer present and the treatment is complete, so you have to use personal history of malignant neoplasm codes from Z category, from Z85. So if a patient is still receiving treatment, still he uses active cancer codes, C codes. And then anemia, pain, or other conditions due to cancer. So in this situation, you have to code malignancy first. So then you have to code any other associate conditions, for example, like anemia due to cancer. So as I said you have to always use a benign neoplasm coding in the alphabetic index, but not the tabular list. So the neoplasm table is located in the alphabetic index. So it organizes neoplasms by site and also behavior. Behavior based upon benign, malignant, in situ, etc. So why this matters? Because jumping directly into tabular list, it can lead to wrong behavior selection. So when histological terms are documented, if the histological type, that is cell type, is documented, so you have to look up the first term first. For example, like histological terms is adenoma, carcinoma, sarcoma, lymphoma, and melanoma. So document states adenoma. So what is the correct step for coding? You have to look up adenoma in the alphabetic index. So then follow the instructional note. See also neoplasm by site and benign. So then you have to locate the organ or site in the neoplasm table. So histology helps you to choose the correct column in the neoplasm table. So understanding the neoplasm table columns. So neoplasm table, it gives different codes for the same site depending upon the behavior. So malignant primary means original cancer site. Malignant secondary means metastatic site. Carcinoma in situ meaning is localized cancer. Benign is non-cancerous. Uncertain behavior is that a pathology is unclear, whereas unspecified behavior is no behavior documented. So selecting the wrong column leads to the incorrect code. So even if the site is correct. So verify the code in the tabular list. So after selecting a code from neoplasm table, so always verify it in the tabular list to confirm code accuracy, to check for laterality, additional digits, excludes nodes, and more specific site codes. So what is the golden rule over here? You should never assign a code without tabular verification. And next is genetic susceptibility to the cancer. So assigning Z15.0 codes. So this references section IC21 for Z15.0 codes. So what is Z15.0? It is a genetic susceptibility to malignant neoplasm. For example, like BRCA1 or BRCA2 gene mutation. So it's a family history with confirmed genetic risk. So Z15.0, it is not a cancer diagnosis. So it is used when the patient does not have cancer, but he has a genetic risk. So next guideline is admission or encounter for treatment of the primary site. So if the primary malignancy is a main reason for the encounter or admission and the treatment is directed at that site. So you have to code the primary malignancy as the principal or first listed diagnosis. So example like if a patient admitted for chemotherapy for lung cancer, so you have to assign C34 point codes. So which denotes malignant neoplasm of lung is the principal diagnosis. So you should not code symptoms like pain or weight loss as a principal when cancer treatment is the reason. So next is exception guideline. So exception to primary malignancy versus principal diagnosis. So normally when a patient is admitted for cancer treatment, the primary malignancy is coded as the principal or first listed diagnosis. So what is the important exception here? If a sole purpose of the encounter is chemotherapy, immunotherapy, external beam radiation therapy, then you should not code the cancer first. You have to give the chemotherapy, immunotherapy codes first. So Z51 is the first listed or principal diagnosis, and malignancy code, C code, it is assigned as a secondary diagnosis. So here Z51.0 for encounter for radiotherapy, Z51.11 is assigned for encounter for anti-neoplastic chemotherapy, whereas Z51.12 is assigned for encounter for anti-neoplastic immunotherapy. So there is an example. patient is admitted only for chemotherapy for colon cancer. So now you have to assign Z51.11 code for principal diagnosis and C18 category code as a secondary diagnosis for colon cancer. So Z51 codes indicate the purpose of visit but not the disease. And then admission or encounter for treatment of secondary site. So when a patient has primary cancer with metastasis, so treatment is directed only at the metastatic, that is a secondary site. So you have to code the secondary malignancy as the principal diagnosis. So even though the primary cancer still exists. So there is an example. If there is a breast cancer with bone metastasis admitted for radiation to bone, so you have to assign C79.51 for secondary malignant neoplasm of bone, which is a principal diagnosis. And then C50, which is a primary breast cancer as a secondary diagnosis. So do not assume primary cancer is always a principal diagnosis. So next come by coding and sequencing of the complications. So how do you code the complications? So cancer and its treatment often cause complications. So ICD-10 provides specific sequencing rules for these. What is the first rule? Anemia associated with malignancy. So here is a scenario. A patient is admitted only for treatment of anemia. So anemia is due to malignancy itself and cancer is not being treated during this encounter. So what is the correct coding sequence here? The first code is for anemia. Anemia in a neoplastic disease, that is D63.0 code, which is assigned as a principal diagnosis. And C code for malignancy is assigned as a secondary diagnosis. And the second example is lung cancer patient admitted for blood transfusion due to anemia caused by cancer. And again here, D63.0 is a principal diagnosis and the cancer codes will be always assigned as a secondary diagnosis in this case where anemia associated with malignancy. This rule applies only when anemia is due to cancer but not the treatment. So when anemia is due to malignancy itself, a patient has cancer, anemia is caused by the cancer, encounter is not solely for anemia management. So you have to code the malignancy first, followed by the anemia code. The second condition is anemia associated with chemotherapy, immunotherapy and radiation therapy. So this is different from anemia caused by cancer itself. The first condition, anemia due to chemotherapy or immunotherapy. So this is an adverse effect. So anemia is caused by adverse effect of the treatment. So encounter is only for anemia management. So what is the correct sequencing? First, code anemia, second cancer, and third at last you have to code the adverse effect. So D64.81 is assigned for anemia due to anti-neoplastic chemotherapy and C code that is for underlying malignancy and then at last T45.1 X5. This is for adverse effect of anti-neoplastic and immunosuppressive drugs. So this is how you have to sequence the codes when anemia associated with chemotherapy. Then anemia due to radiation therapy. So you have to sequence first the anemia, then malignancy code and then Y84.2 category codes for radiological procedure and radiotherapy causing the abnormal reaction. So example like prostate cancer patient with anemia caused by radiation therapy. So D64.81 is assigned as a principal diagnosis, C61 the malignancy code as a secondary diagnosis and Y84.2 is given as an additional diagnosis. So radiation code will always be at a last. And third guideline is about management of dehydration due to malignancy. So patient has cancer. Dehydration is caused by the malignancy. So encounter is only for dehydration treatment. So how do you code here? What is the correct sequencing? First you have to code dehydration, that is E86.0, which is assigned as a principal diagnosis, and then C code for malignancy, which is secondary diagnosis. This is how you have to give code when encounter is for management of dehydration. So dehydration is always coded first, followed by the malignancy code. So when a complication is the reason for admission, so you have to always code the complication first. And the next guideline is about treatment of complication resulting from a surgical procedure. So patient previously had cancer surgery. Now he has admitted for post-surgical complication. So treatment is directed at the complication but not the cancer. So what is the sequencing rule over here? Code the complication as a principal diagnosis. For example, patient status post-colon cancer surgery, admitted for post-operative infection. So you have to give code TIT1 series for infection following a procedure as a principal diagnosis, and then C18, which is for colon cancer, is assigned as a secondary diagnosis if still it is present. So treat what is being treated first, regardless of the cancer history. And next guideline is regarding primary malignancy previously excised. So when to use this? So it denotes Z85 codes. So when to use Z85 codes? For personal history of malignancy. So you have to use Z85 when a primary cancer has been completely removed or eradicated from its site. So there is no current treatment to that site. There is no evidence of existing cancer at that site. For example, patient with history of breast cancer, status post-mastectomy, and there is no recurrence. So you have to assign Z85.3 code for personal history of malignant neoplasm of the breast, and Z85 for active cancer. And then metastasis after primary cancer removal. So even if the primary cancer site is gone and it is spread to the another site, is still coded as an active secondary malignancy. For example, colon cancer removed. Later, liver metastasis documented. So how do you code it? First, you have to give history of colon cancer codes. Then you have to assign C78 code for secondary malignant neoplasm of liver. So metastasis is always an active cancer, never a history. So you have to always code active codes for secondary malignant neoplasm. So next is extension, invasion, metastasis after primary cancer removal. So what is the key rule here? If documentation mentions extension, invasion, metastasis to another site, you have to code it as a secondary malignant neoplasm, that is from category C77 to C79 of that site. So the secondary malignancy may be a principal or first listed diagnosis, and Z85, that is history of cancer codes, is used as a secondary code to show the original site. For example, colon cancer previously removed. Now liver metastasis is treated. So assign C78.7 for secondary malignant neoplasm of liver as a principal diagnosis, and Z85.038 for the history of colon cancer as a secondary diagnosis. So once cancer spreads, it is an active cancer but not a history. And then coming to E guideline, admissions or encounters involving chemotherapy, immunotherapy, and radiation therapy. So this involves when to code the cancer first versus when to code Z51 first. So the first guideline is episode of care involving surgical removal of neoplasm. So patient undergoes surgical removal of tumor. During the same episode of care, patient also receives chemotherapy or radiation therapy. So what is the sequencing rule for this encounter? So neoplasm code is always the first listed or principal code. Example, patient admitted for mastectomy followed by radiation during the same stay. So first you have to assign the code for breast cancer, which is a principal diagnosis, and then Z51.0 for radiation therapy as a secondary diagnosis. So if the surgery is the main event, cancer comes first. And then next guideline is admission or encounter chiefly for administration of chemotherapy, immunotherapy and radiation therapy. So patient admitted only for therapy. There is no surgery performed during this encounter. So what is the sequencing rule? Z51 code is always a principal and first listed code or first listed diagnosis. So generally we assign Z51.0 for radiation therapy, Z51.11 for encounter for chemotherapy and Z51.12 for encounter for immunotherapy. So this is how you sequence the codes when the encounter is only for therapies but not for the surgical treatment. So if a patient is admitted chiefly to receive therapy, the Z51 code is sequenced first. If more than one therapy is given in the same admission, so you should assign multiple Z51 codes so they can be listed in any sequence. For example, patient is admitted for both chemotherapy and immunotherapy for melanoma. So how do you sequence? First for chemotherapy and second for immunotherapy, and at last as a secondary diagnosis, you have to assign the code C43 for melanoma. So multiple Z51 codes are allowed only when multiple therapies are actually given. Coding the cancer when therapy is given. So the malignancy being treated must be coded as a secondary diagnosis when the encounter is chiefly for therapy. For example, like patient receives chemotherapy for ovarian cancer. So first you have to sequence encounter for chemotherapy code, that is Z51.11, and then C56 for ovarian cancer. Therapy first and tumor next. So here is an exception. Insertion or implantation of radioactive elements, that is brachytherapy. So the encounter is for insertion or implantation of a radioactive material, for example brachytherapy, you should not use Z51.0. So the malignancy code becomes the principal diagnosis. And patient admitted for therapy and develops complications. So what will be the common complications? Uncontrolled nausea and vomiting, dehydration, electrolyte imbalance, anemia due to chemotherapy. So what is the sequencing rule? Even if complications occur, you have to code Z51, which remains as a principal diagnosis, and the complications are coded afterwards. For example, patient admitted for chemotherapy develops severe dehydration, where Z51.11 for encounter for chemotherapy, E86.0 for dehydration, and C18 for colon cancer. So complications, they do not replace the therapy code as a principal code. So when the patient is admitted for insertion or implantation of radioactive elements and he develops complications such as uncontrolled nausea and vomiting and dehydration. So how do you sequence the codes? So the malignancy code is a principal code followed by the complication code. So why this is important? Because this is not considered as a routine radiation therapy encounter. That's why Z51.0 should not be used. Here is an example. Patient admitted for brachytherapy for cervical cancer. He developed severe dehydration. So what is the correct coding? You have to code C53, that is cervical cancer, as a principal diagnosis, and E86.0 for dehydration. Our next guideline, F guideline, is admission or encounter to determine extent of malignancy. So what does this mean? So the patient is admitted to determine how far the cancer has spread. So perform diagnostic or evaluative procedures such as paracentesis, thoracentesis, biopsy, imaging or staging workup. So even if chemotherapy or radiation is given during the stay, it is not the primary reason for the admission. So what is the sequencing rule in these cases? So primary malignancy or metastatic site is coded as a principal diagnosis. So what is the purpose of admission? is always the evaluation or staging, but not the treatment. And next guideline, symptoms, signs and abnormal findings associated with neoplasms. So symptoms and signs. So these are available in the chapter 18 codes. For example, like pain, weight loss, anemia, nausea and fatigue. So what is the core rule over here? Symptoms associated with an existing malignancy. So you should not replace the cancer as a principal diagnosis even if the patient is admitted multiple times. So what is the example? Patient with lung cancer admitted for chest pain due to a tumor. So always code lung cancer as a principal diagnosis and chest pain, that is from chapter 18 R series code, as a secondary diagnosis. So always remember the chapter 18 codes or the signs and symptoms, they must not be assigned as a principal diagnosis. They should always be assigned as a secondary diagnosis. So if the cancer is present, symptoms bow to the cancer. If admission is for prophylactic organ removal, that is there is no cancer present yet. So you have to use Z codes but not the malignancy codes. For example, a patient with BRCA mutation undergoes preventive mastectomy. So what will be the correct coding? Z40.01 for encounter for prophylactic removal of breast. So there is no cancer yet, you have to assign Z code. If cancer is present, you have to assign C code. So this is how you have to assign the neoplasms with the complication codes. So this is for today's session. I hope this session has helped you. So in the next session, you will be learning about the continuation of ICD-10 CM coding guidelines for neoplasms. Thank you.